iGlaucoma presents Podium Presentations on Glaucoma Rewind for national presentations that were missed or those you watched but wish you could press rewind and watch again. In today's podium presentation, the talk was presented at the live virtual meeting Eyes On 2022 with over 5,000 live attendees. Today to have the opportunity to talk to you about advanced technology lenses in patients with glaucoma. IOLs have first came out in the early 1950s as a monofocal lens. And since then, we've had patients who've had desire to have less dependence on lenses. And that has sparked a number of different technologies and developments in the areas of IOL designs. We now have toric lenses, bifocal lenses, multifocal lenses, trifocal lenses, as well as an extended depth of focus lenses and monofocal plus lenses. All of these lenses with a desire to try to allow the patient to have what they want, which is excellent vision, but with less dependence on the glasses. Now, with the advent of the development of the multifocal lenses, these were to allow for patients to see at different distances, far away, intermediate, and near. But the designs did have some drawbacks. And one of the major drawbacks is in the design with the splitting of light, this can lead to reduced contrast sensitivity. This is something that we'll talk more about because it does affect patients who have glaucoma. Also, with the design, there can sometimes be a decrease in the quality of vision, and this can lead to complaints or just not being happy in certain light settings, like dim light settings. And then they also have a tendency to have the ability for dysphotopsias, which can also become a problem with certain patients. So the trade-off of having less dependence on glasses, more range of vision, does come with the ability of possibly having reduced contrast sensitivity and an increased risk of dysphotopsias, which in patients who have glaucoma, this can be a problem because they already have conditions that allow for reduced contrast sensitivity, and they already have issues related to things such as glare. And so trying to decide if they can be candidates or who can be candidates is what we're going to be talking about today. Some of the considerations that you have to think about for patients who have glaucoma, different from a patient with a normal eye and not that condition, are that they can often have small pupils. This can be related to certain drops that they might be using chronically, such as pilocarpine, or maybe they have uveitis as a component of their glaucoma, creating sneaky eye formation. They also have a tendency to have anterior capsule contraction as well as posterior capsule opacification. And they can have certain types of glaucoma that lead to zonular instability, like pseudoexfoliation syndrome, where you might have to be considering how the lens position is going to be further on, decades from when the procedure was done. In terms of the functional status for glaucoma patients, things that we have to consider is just their overall satisfaction. Patients with glaucoma already can have decreased vision because of their glaucoma, so trying to make sure that we maximize and not minimize things. They can have decreased contrast sensitivity. Sometimes if one wants to combine a cataract surgery with certain glaucoma procedures like a trabeculectomy, there can be issues related to postoperative stigmatism creation or refractive error. And then also one has to know that there are some lenses, some multifocal lenses that can actually be a detriment to the follow-up care for glaucoma, causing some type of decrease in the ability to monitor things such as visual fields and OCT. So I want to go move into now talking about some of the literature that we do have. There is a very small amount of literature that we have in glaucoma and advanced technology lenses. But let's at least share where we are now. So first talking about toric lenses in glaucoma. Toric lenses help correct corneal astigmatism, and this is really widely accepted to be used in patients who have glaucoma. And the reason for that is because these are monofocal lenses. There's no splitting of light, and so this allows for patient to see at that focal point their best vision. Also, they're able to see the clearest in the areas where they can see, and with these lenses, there's no issues related to follow-up care or follow-up testing, and it does allow for some level of spectacle independence. I know I have a patient who has advanced glaucoma, and his desire was to be able to see at distance in order to go fishing without glasses. He had glaucoma and it was advanced, but his central zone was maintained over several years. We decided to do a toric lens on this patient, and he's had, combined with a MIGS procedure, and he's had stable glaucoma and stable, excellent central vision, and been able to be happy being able to fish without glasses. Here is a study that looks at toric lenses in patients who have glaucoma. This is a single center retrospective study of looking at the Acrosoft toric lens in patients who have glaucoma with astigmatism. There was 126 eyes of the 87 patients, and they did find good results, with 98% of patients having 20/40 or better vision and 47% achieving 20/20 uncorrected distance vision. In terms of the refractive error that was residual, there was 97% that had 1 diopter or less, and 83% of eyes had 0.5 diopters or less. So showing that toric lenses can be very beneficial in patients who have glaucoma. Here's a study looking at toric lenses that were put in patients alongside with patients who had non-toric monofocal lenses, but both of them were combined with a certain type of MIGS procedure, goniotomy procedure called the microhook ab-internal trabeculotomy. And in this retrospective study, they looked at these two categories of patients, either having the toric correction or not, but both of those groups having the goniotomy procedure. 20 eyes total, with 10 eyes in each group. What they found is that there were significant improvements in the uncorrected visual acuity. It was very similar for both groups. What they found was that in the group that had the toric lens, that there was a statistically improved outcome compared to the non-toric or the monofocal lens, but there wasn't any difference in terms of their best corrected visual acuity or their surgically induced astigmatism. And these were factors to be able to evaluate if there was stability in terms of doing the MIGS procedure along with the toric or non-toric lenses. And so overall, they found that toric lenses can be implanted well in the MIGS procedure, this goniotomy procedure, without concern of it having an effect on the ability to have excellent outcomes for the distance uncorrected vision. So we have a number of different premium toric lenses. We have the Tecnis toric Eye-Enhance lens, the Acrosoft IQ toric lens, and the Invista toric lens. And I'm going to highlight on one of the newer lenses, which is the Tecnis Eye-Enhance lens. And this is a monofocal IOL that also provides excellent intermediate vision, delivering on excellent distance vision and also having a certain type of refractive design that is progressive in power. It is a lens that has been shown to have low incidence of dysphotopsias, and one of the nice features of it is that it is preloaded. So if you're ever in a situation where you have concern about the staff being able to load the lens consistently or well, this is a design where one doesn't have to think about that by having it already preloaded. The Eye-Enhance IOL looks identical to the Tecnis one-piece lens, but what it does differently is that it has a continuous change in power from the outside in. And this is what allows for the ability to have both that strong distance vision as well as enhanced intermediate excellent vision. It is not something that is based on a zonal design or a spherical aberration design, but it does have the ability to reduce spherical aberrations to near zero. So here is the defocus curve looking at the Eye-Enhance lens versus the one-piece monofocal lens, the Eye-Enhance lens being in the purple and the one-piece monofocal in the green. And what can be seen here is that at distance vision, the vision is excellent at 20/20. As you go down the defocus curve into the intermediate zone, one can see how there's an advantage of the Tecnis Eye-Enhance over the monofocal lens of being able to deliver better quality intermediate vision. Now, also, the Eye-Enhance has been shown to have some level of improvement in terms of contrast sensitivity. And here on the graph, we have the various lenses being evaluated, the Tecnis one-piece, the Tecnis Eye-Enhance, the Acrosoft SN60 WF, and the Acrosoft SA60 AT. And the gray is the 3 millimeters of the pupil size versus the green, which is the 5 millimeter pupil size. And here, the 5 being as if in dim lighting. And you see that the Tecnis Eyhance does seem to outperform the other Acrosoft lenses in terms of the MTF ability to enhance that image contrast. Now, one of the things that you do need to consider with toric lenses and glaucoma eyes is that sometimes you might have small eyes or small pupils, and you have to expand them with pupil expanders. And then after one has to remove the pupil expander, the pupil can come down, and this can sometimes limit your view of the toric markings. And so that's something that one has to be able to manipulate the eye to make sure that the lens is appropriately aligned. And then also sometimes one has to be cognizant of zonular weakness. And so one may use the capsular tension rings in order to help stabilize the capsule. And thinking about patients, maybe patients who have pseudoexfoliation where maybe they didn't have any sign of zonular dehiscence at the time of the surgery, but one wants to prevent that from happening and just provide extra stabilization with the use of that type of ring. Now switching focus from toric lenses to multifocal lenses in glaucoma. Again, this is an area that there's still not a lot of research in this area, but there is some. When we think about multifocal lenses, again, we talked about this earlier, they can have the ability to allow patients to have spectacle independence at a distance intermediate and near. It can help improve their quality of life. It can also have the ability to reduce the amount of falls. But in patients who have glaucoma, part of the reason why it hasn't been completely widely accepted in all patients of glaucoma is because multifocal lenses do split the light, and that can cause a reduction of their contrast sensitivity in patients who already have risk for that reduction. Also, there can be the halos, the glare, trouble at night vision. These are all issues that are already present with patients with glaucoma. And there have been studies that have shown that there can be interference of multifocal lenses with visual field testing, where there's decreased visual sensitivity with multifocal lenses. And then also sometimes with certain types of OCT technology, there could be artifacts that can compromise the results. So these are things that are important to be thinking about with our glaucoma patient population. Here's a study that looked at using multifocal lenses in patients who had cataracts and other existing pathology. Here, it wasn't a focus on glaucoma, but there were some glaucoma patients within this study. And what they found, there were 4 patients out of 15, so a small study. They did have an ability for the patients to have good distance vision with not having to use spectacles for distance vision and being satisfied with their far vision. But there were about 20% that did need to use glasses for near vision. In this study, they did say that contrast sensitivity in all the eyes was comparable to that of normal healthy subjects. But again, the study wasn't able to really delineate specifically for glaucoma, and it was a small size. Here's another study that looked at the actual visual function and the patient satisfaction in patients who had multifocal lenses, who had either glaucoma or dry macular degeneration. And in this study, it was a retrospective study. They had 9 patients who had glaucoma who were pre-parametric and 9 that had parametric glaucoma, so 18 patients in this study who were looked at for glaucoma. And the different lenses that they had were the Acrosoft Restore, the Panoptix lens, a trifocal physio lens, or the Tecnis Symphony extended depth of focus lens. And what they found in their study was that the healthy and pre-parametric patients, they had more complaints of halos much more often than those patients who had parametric glaucoma or dry AMD. And in those patients, they did seem to suffer less from glare. But patients who had glaucoma and dry AMD had more difficulties when driving at night. And patients who had glaucoma and dry AMD did tend to have more requirement of spectacle correction for the near. And so here they were able to deduce that in patients who had pre-parametric glaucoma, so very mild, no signs of any kind of visual field loss, and comparing those to healthy eyes, they were comparable. So maybe they're shedding light that patients with very early disease could benefit from a multifocal lens. And in this study, it was a multifocal lens that was evaluated in patients who had different types of other eye diseases. They were varied, but they did include patients with glaucoma, as well as macular degeneration and diabetic retinopathy. This was 81 eyes that had a multifocal lens implanted and 52 with a monofocal lens design. Out of those eyes, 11 to 12 were in each of the various groups of IOL. And what they were able to find was that they did see that there was a benefit of patients who had glaucoma in the first graph that did benefit from uncorrected distance vision being excellent, compared to patients who had monofocal IOLs. They did, and the multifocal group did seem to have better, best corrected visual acuity in the arm that had the glaucoma. So what we can take from the multifocal lenses in glaucoma is still a bit controversial. I would say that it seems like patients who are very mild, who have very preparametric glaucoma, very mild disease, maybe your glaucoma suspects, ocular hypertensives, I think that these patients could actually do well with multifocal lenses. But in patients who have either moderate or severe glaucoma, where there is reduced visual acuity on the visual field, and especially if it encroaches anywhere close to fixation, I think that these lenses are not as ideal. But we don't have large trials to be able to give us evidence, so hopefully that will be coming out soon. Now, shifting gears from multifocal lenses to extended depth of focus IOLs, here we have a class of IOL that now allows for extended range of vision, so excellent distance vision, excellent intermediate vision, and very good functional near vision. So still might need to use reading glasses for very small print, but most things being able to see like the phone or the putting on makeup at the mirror, being able to do things that are helpful functionally. And so we have two lenses here in this category to discuss. So the Tecnis Symphony lens, which came out in 2016, and the Acrosoft IQ Vivity lens that came out recently in 2020. So with the Tecnis Symphony lens, this is an extended depth of focus lens that has diffractive technology. And so here, the design where they have an echelet feature, this helps to elongate the range of vision. And also with this technology, they have the ability to reduce chromatic aberrations, which actually help with some of the contrast, enhancing contrast sensitivity. So with chromatic aberrations, these cause out of focus blur and reduction of contrast. And the chromatic aberration does have the ability to be corrected with a diffractive IOL technology. And here we have the ability to use this technology to correct the elongated chromatic aberration and then allow for this to increase contrast. And then also with the ability of correcting corneal chromatic aberration, this allows for a sharper focus of light. And this combined together can help to increase the retinal image to allow for more ability to see more sharply without affecting the depth of focus. And one way to evaluate this contrast enhancement is with the modulated transfer function, which we mentioned earlier. And this is something where you measure the amount of contrast that's coming, that's being transferred by optics in a visual system. And the higher the MTF, the more ability for the contrast to be transferred and the higher contrast sensitivity. And so with the Tecnis Symphony lens, this lens had the ability, seen here in the defocus curve, to have excellent distance vision. And then as moving down the defocus curve into the intermediate zone, also excellent vision at intermediate zone with the ability to have some good functional vision at the near zone. Part of the issues, though, with the diffractive lens technology is that with the rings, there is a bit more ability for there to still be some dysphotopsias. So where one is getting that extended depth of focus, there may be still some limitation in certain levels of glaucoma with that a bit potential for the glare. So as we have been expanding in technologies, we have expanded in the area of the extended depth of focus IOLs with non-diffractive technology. Now, this allows for monofocal-like distance, also with excellent intermediate and very good functional near. Now, because of the design and the lack of rings, there is less visual disturbance, less halos, and also because of the lack of rings in the non-diffractive technology, this allows for the ability to not split light, which helps with the contrast sensitivity. So with the non-diffractive extended depth of focus lens, the Vivity lens provides this technology. And in the clinical trial that allowed for the Vivity lens to be approved, what was shown was that the Vivity lens has excellent distance vision, delivering 20/20 at distance at least greater than greater than 20/25 at intermediate, so excellent intermediate distance, and then very good functional near at 20/32 or better. And I have found that this is also something I'm seeing in my my clinic practice with this extended range, and actually have been surprised to see some at a better outcomes even for the near vision. Here we can look at the defocus curve, and one of the advantages of this type of technology is that one can call the lens very forgiving because it has a wide landing zone here on the defocus curve where that ability to see 20/20 or better, there's a wide range of that. As one goes down the defocus curve into the intermediate zone, you're still here having excellent intermediate vision at 20/25. And then as you get into the near zone, you still have very good functional near. And for a patient who desires, who has glaucoma, but desires to have less dependence on glasses and that ability to have more range, this provides that with, as we'll see, less of the dysphotopsias, which is a major concern for our glaucoma patients. So here in the evaluation of the Vivity lens compared with the Acrosoft IQ monofocal lens, a questionnaire was given in the clinical trial. And one of the questions asked was, in the past 7 days, how much were you bothered by starburst, halos, or glare? And what we see with the responses are that it's very similar. You see that the green is the Vivity lens and the Acrosoft monofocal is the orange. And in all of those categories of starburst, halos, or glare, only 2% were very much bothered by starburst, only 1% by halos, and none very much bothered by glare. So again, with this technology, we're seeing less and less complaints of these dysphotopsias. And now another way of looking at the non-diffractive lenses and how they're doing in patients, how the patient's vision is in either bright lighting or in dim lighting. Here the patients were in the clinical trial were evaluated with a questionnaire that asked about how well they saw their vision without glasses in bright light settings as well as dim. And we see here comparing the Acrosoft Vivity lens to the Acrosoft monofocal lens, being the monofocal in orange and the Vivity in green. Patients did very well seeing in bright light far away, even better at intermediate for the Vivity lens, and very good at up close. Now, in the dim light settings, we see that it's still very comparable, where the far away is excellent, intermediate is excellent, and then still very good at up close. And so this lens having the ability to help patients who are going to have issues with contrast sensitivity. So even in dim lighting, still being able to have very good outcomes visually. And part of the reason for the ability to have these benefits of extended range of vision with limited dysphotopsias is with the X-wavelength technology, where they're stretching and shifting light and not splitting it. With the raised design that's seen centrally on the IOL, you have to actually look at it in a side profile to be able to see the areas that are raised centrally, the central elements, and this allows for there to be that extended range of vision. And here, as we look at the light distribution in various different lenses, we can see how in the Vivity lens X-wave technology that there is this extended focal range. And what's important about it is that it is continuous. There isn't an area where there's actually a lessening or a diminishing of light. So you have no splitting of the light. And so that's why there is that ability to have that good contrast sensitivity and less dysphotopsias. And here's another evaluation of the concept of how halos can be measured using optical bench halo measurements, comparing the Acrosoft monofocal IOL to the Vivity lens and to the Technis Symphony, but with diffractive technology. And you can see that the Vivity halo that is produced is very similar to that is produced with the monofocal. But when you compare to the diffractive technology, you see how there is an much different appearance of the halos. And again, part of the reason why this technology is doing well with glaucoma patients. So now that we've discussed various types of advanced technology lenses, let's go into some practical discussion about how we do go about considering these lenses in glaucoma patients. One of the first questions that needs to be answered is, how severe is their glaucoma? If we're talking about patients with mild glaucoma, is it moderate? Is it severe? And in measuring the severity, is this a patient that has stable glaucoma? Are they on quite a number of medications? Are we looking to remove medications? Are we looking to stabilize their glaucoma? And then also, it's important to consider their ocular surface. Is there a significant ocular surface that needs to be addressed here in this picture? And then also, it's on the bottom, but it's also very important, is what is their desire? Do they have a strong desire to have less dependence on glasses? That has a major impact on the outcome, because if they're motivated to try to have less dependence on glasses, these are people who, when explained what their expectations are, can be much more understanding, or because they're motivated to try to have less dependence, because that's very important to them. Now, who's an ideal glaucoma candidate? Well, ideally, the less glaucoma, the better your outcome can be, because you're not competing with any kind of other level of impairment. So patients who have ocular hypertension, glaucoma suspects, very mild glaucoma, pre-parametric glaucoma, and these are going to be great candidates if they're well controlled and if their visual fields are minimal, as in pre-parametric or very minimally peripheral defects. So these are patients who, if you just thought glaucoma, don't even think about an advanced technology lens. These are definitely the ones that you should be considering and stretching that envelope to offer them multifocals or extended depth of range IOLs. Now, there are then the poor candidates that are sometimes very obvious, the ones that have advanced disease, if they have any kind of central visual field defect, if their glaucoma is very poorly controlled and aggressive, if they have high risk for progression, if they're these are patients that may need a trabeculectomy or may need a tube shunt, and those don't marry as well with these advanced technology lenses because of the astigmatism that they create. And if they have a really heavy medication load, they may have a lot of difficulty with getting their ocular surface under control. But I will say that the design of the non-diffractive extended depth of focus IOLs has allowed for my expansion to include more patients who have glaucoma, more of the mild and parametric glaucoma to moderate parametric glaucoma, and having good outcomes, because these patients, whether they may be controlled or maybe not quite, maybe uncontrolled, but they could be candidates for, say, a combined MIGS procedure. Their visual fields, like seen here, with some peripheral defect, and the more maybe more mild to moderate, maybe in both hemispheres, but still peripheral. These are patients that have been, at least in my experience, in my hands, been showing signs that they can do well with this type of technology. Now, in the perioperative evaluation, one does need to be very committed to trying to explain as best as possible where they stand with their glaucoma so that they can set expectations. So I will always have a visual field that's at least within 3 months old or that day, to be able to show them where they are with their glaucoma. And I will explain to them in pictorial form of what a normal visual field looks like. They'll see that. And then I'll show them what their visual field looks like. And I'll explain to them where their blind spot is naturally and where their blind spots are from glaucoma. And then I will put my hand over the visual field and say, a cataract is like a film on top of this. And when I move the cataract away, when we remove it, what's left is areas where it can be enhanced. So if it's in a light gray area, white to light gray area, these are areas where you can expect to have enhanced vision. In any areas that are black, dark gray to black, absolute black, these are areas that are permanent blind spots from glaucoma. They need to have an understanding of where their glaucoma is, so they can also understand afterwards, when that cataract goes away and they're left with what's remaining of their glaucoma, they have at least been explained that this is the difference. And if they need to be re-explained afterwards, at least they can recall about what you had said and say, okay, that's right, you did say that, I understand. And so now you've set that expectation, as opposed to not having that conversation and they're wondering why they're not seeing better, and you didn't talk to them about their level of glaucoma, and they're disappointed. So that's a very important aspect of the evaluation. Now, in terms of the assessment for a patient who has glaucoma and cataracts, we're also assessing their glaucoma to decide if it's controlled. If it's controlled, do we have the opportunity to have less dependence on eye drops, which is beneficial for their ocular surface and can enhance their visual outcome? Are they uncontrolled, and do they seem to be someone who could be controlled with a internal MIGS procedure? And these are things that you want to be able to evaluate. Now, I will say that I have had experiences of, say, a patient who has had a trabeculectomy or a tube shunt, and these patients can have these type of lenses that can correct astigmatism and allow for extended range, but they have to have a stable refraction. And so you're talking about people who, let's say someone had really high pressures, but their glaucoma wasn't so advanced and they needed to have a trabeculectomy to help to control the pressure, but their nerves are still pretty stable, healthy, and their visual field damage is not a lot. They can have these type of lenses if they have a stable refraction, because you can correct the astigmatism at that point, and then give them also the extended range of vision if that's what they're desiring. Some of the considerations when implanting these lenses in glaucoma is also the dysphotopsias. And as I mentioned, there seems to be less of a concern with this with the non-diffractive type presbyopic correcting IOLs, less of concern with toric IOLs, but have concern in patients who don't have pristine visual fields, and having that discussion, because it can be very problematic in patients who have glaucoma who may progress, have risk of the progression. And then also one needs to consider correcting the ocular surface. If there is ocular surface disease, just as in any other cataract surgery that is a refractive cataract patient, we need to address the corneal surface and do what we can in order to help improve that, whether by medications, whether by technology that addresses the meibomian gland function, or punctal plugs, vitamins, any or many of the above. And then if you have any patients who have any kind of corneal edema. I've had multiple glaucoma surgeries. Sometimes you have to, know where your limitations are, and they may not be, they may be red flags and maybe not the best candidates. One has to also, we talked about multifocal lenses in glaucoma patients, being very cautious with them, and anything that's more mild to moderate disease. But I want to say something about monofocal patients or monovision patients. I tend to dissuade patients who have advanced glaucoma, moderate to advanced glaucoma in one eye and very mild in the other eye. I dissuade them from monovision because you're putting all your weight of vision on one eye. And if you have glaucoma that is significant in that one eye, it's likely that the progression, there's more risk for progression. And so at some point, they won't be able to utilize that eye well for that function. And then they're going to be back in glasses. And I've had a patient who who was a monovision patient, had advanced glaucoma in one eye and mild in the other eye. I tried to dissuade her from doing that. She was adamant about wanting to mimic it. And after, she now carries so many different kinds of glasses to try to accommodate for herself at the various distances, and not as happy of a patient as I think that she would have been if we were able to allow her to have equal distance, equal vision in each eye at the same focal point. Now, in terms of choosing the correct IOL for patients, toric lenses, as we mentioned, are very good for patients who have glaucoma, and even in patients who have advanced glaucoma, as I mentioned with my patient as an example. But I don't combine toric IOLs with trabeculectomies or tube shunts at that time because of the inconsistency of the outcomes and the development of the potential astigmatism afterwards. But I would give at least 6 months or more afterwards to be able to have them have a stable refraction and then be able to do the cataract surgery out afterwards with expectation that the outcome can be very good. This is some of what I've already discussed in terms of making sure that you have a good discussion with the patient in terms of their expectations, setting expectations up well so that they can be able to have an excellent outcome, and also to talk about the advantages and the disadvantages of where they are with the technology that we have, and limitations with reading. I always let them know that they're going to need reading glasses so that they can expect that. And then when they feel like they're seeing better than needing the readers all the time, then they can have a positive expectation or positive outcome. Now, I wanted to just review a case of a patient that had one of our advanced technology lenses. This is a 77-year-old female who had glaucoma and visually significant cataracts. It was referred to me by her optometrist for an evaluation of cataracts and glaucoma. The patient was very active and wanted to be able to have the best vision possible with the least dependence on glasses. She was currently using Xalatan in both eyes, and her pressures were 17 and 19 with pachymetries of 571 and 563. On her exam in the slit lamp, she had some SPK in her corneas, and she also had evidence of meibomian gland dysfunction in both eyes. Otherwise, her exam was normal in the anterior segment. She had a cup-to ratio of a 0.5 in the right and 0.65 in the left, with in the left eye a superior thinning with an early notch. Gonioscopy, she was wide open with 1 to 2 plus pigment. And on her visual field, she did have superior arcuate in the right eye, and in the left eye, an inferior arcuate into the nasal step with a secocentral scotoma that was encroaching, which is close to, but not quite yet in fixation. On her OCT, she had a borderline infratemporal and temporal thinning as seen here, and then also in the left eye, superior temporal and temporal thinning. I don't think I mentioned that on her exam in terms of her cataract, she had a 2 to 3 plus nucleus sclerotic cataract with 3 plus cortical spoking, and also about 1 to 2 plus PSC.
in both eyes. On her evaluation, preoperatively, we like to get several different measurements to compare and assess for similarity. So we got a lens star, a NIDEC OPD, and then also utilized Cassini in order to be able to evaluate her spherical measurements as well as her cylinder, and found it to be very consistent. For her, our plan was to we used the Toric calculator, found that she did have astigmatism that would benefit from correcting, and so we used a Vivity Toric IOL with her, a 20 diopter DFT 315 at 170, and then we also combined this with a MIGS procedure. We opted for a trabectome procedure for this patient to enhance her glaucoma by lowering the eye pressure and trying to help her get off of her medications. I noted before that she had dry eye disease, and so we also wanted to treat that. We were more aggressive with preservative-free artificial tears, and had her opted for her to have an IOLs procedure to help with the meibomian gland function. Her second IOL calculations were very similar in that we got the lens star, NIDEC, OPD, and the Cassini. For her, she didn't have quite as much astigmatism. So when we did our calculations, we found that she would benefit from LRIs. And so we did utilized a 20 diopter DFT 015 Vivity lens with the Lens X laser, and then combined that also with the trabectome goniotomy in her left eye. She also had the pretreatment with the IOLs. So she did excellent as a postoperative patient. Outcomes were great at distance. She had 20/20 vision. Intermediate was 20/20, and J3 at near, that was in the right eye. And in the left eye, 20/25 at distance. Intermediate was 20/20, and at near J2. And overall combined, 20/20 at distance and intermediate, and J2 at near. In terms of her pressures, she was able to get off her meds. Her pressures came down from preoperative from 16 in the right into 6 and 15 in the left on no medications. She was thrilled and ecstatic with the opportunity to have better vision, to have less dependence on glasses, to have less drops. So it was a real slam dunk for her and for me to be able to offer that to my patient. And so, in conclusion, some takeaways from today's talk, I would say that there's definitely more options that are available for glaucoma patients. We need to be thinking about offering it to our patients. They too are like our other cataract patients who'd like to have less spectacle dependence with good vision. And I think we should offer it to them. We've gone over some of the different options for patients to be considering. I think it's good to set good expectations to have the best outcomes. Remember to talk to the patients about the visual field. Also remember to address the ocular surface, and definitely consider using MIGS with advanced technology lenses. They can go well hand in hand. I thank you for your attention. I'd like to acknowledge Dr. Patrick Wu, who is an EVMS resident, who was very helpful with putting this presentation together, as well as Lauren Mason, an EVMS that's at Eastern Virginia Medical School medical student, who also was very helpful in putting this presentation together. And I'd like to extend a warm invitation to check out my YouTube channel, where I post educational videos on glaucoma. We have the current series on the MIGS Success Surgical Secrets. If you want to learn about common mistakes and how to correct them or avoid them, it's a great series for you to check out. Thank you so much for your time and your attention.
I'd like to welcome everyone back and thank you, Dr. Constance Okeke, who had just a wonderful talk that just finished up here. Thanks again, Constance, for the wonderful overview of really a large topic. And I have a couple of points here that I was going to touch base on from your talk. And so, the first one is, when you're thinking about in patients with glaucoma, and really ranging the whole gamut on the milder side anyways, what are some of the ocular surface considerations you have when considering premium IOLs or even toric IOLs for your glaucoma patients?
Thank you, David. And what I would say in terms of patients with glaucoma and cataracts and dry eye, you do have to address it. We know very well, our research is showing us, clinical experience is showing us that we need to address the dry eye, especially in these refractive patients, if we want to have good outcomes afterwards, as patients tend to go through a dry eye state. And so at the time of the exam for their cataract evaluation, they'll be able to evaluate their cornea and assess whether or not they're actively doing anything for their dry eye. If they are, there's a number of different things that you might treat them with. If you can start with the artificial tears, obviously, but I also use modalities of using prescribed medication for dry eye, such as Restasis, or using medication like Xydra. But also patients may evaluate their meibomian glands in order to assess whether or not there is an area there that needs to be addressed, whether with removing excess exfoliation or excess debris on the lid margin, or treating the meibomian glands to debulk them and rid them of their excess oils. I use a number of different treatments for meibomian gland rehabilitation, like IOLs or a LipiFlow or BluffX. So those are things that I might also offer. The case that I had shown had also addressed using that. So in addition to vitamins for long-term care, warm compresses, it kind of depends on where they're starting, on what they're using, and where they are. But it is important to address all of these needs prior to the surgery, and then also let them know that they might be dealing with it a little bit afterwards. So if you're putting in punctal plugs or having them to continue on these medications afterwards, they understand the importance for their overall quality of vision.
Excellent. Oh, thank you very much, Constance. And another comment that has come up is, so now patients that may be more closer to the relative contraindication of a premium IOL experience and their glaucoma, what are maybe one or two major pearls or takeaways that you'd want to pass on when you're counseling these patients on their suitability for premium IOLs, or even, let's say, a toric IOL?
So I think that it's important to have a really good, frank discussion. And I mentioned some of these points in the talk. The stage of the glaucoma is important. So if you're working with someone who is more moderate to advanced, you're assessing whether or not they have central fixation. If they have central fixation loss, then it's really important to let them know that you may feel that these lenses may not be as beneficial to them. They may actually make their vision worse in terms of contrast sensitivity reduction, which can make their vision quality worse with that lens. So it is important to kind of counsel them. I think that up until recently, there was a lot of patients who were eager and interested to have advanced technology lenses that I had to shy away from because of my concern at their stage of their glaucoma, or also the condition of their glaucoma, whether it's controlled or not controlled with how many meds, a lot or few. But I will say that more recently, I have pushed the envelope in terms of allowing those patients who have a little bit more moderate to even just touching to advanced, if their central fixation is good, with the extended depth of focus lenses that are non-diffractive. I've had very good outcomes with that without harming them in ways of dysphotopsias or the reduction in contrast sensitivity. But when it is more encroaching on near the central fixation, I think that toric lenses still do very well. I've had, and I think I mentioned in my talk, I've had patients who have had still good central vision, although it was constricted, but their level of glaucoma had been stable for quite some time, that still did very well with toric lenses. I think the toric lenses allow for patients to have as best vision as they can with that astigmatism correction. And then, with the advent of some of the newer technologies that we're seeing, even like with the presbyopia drops that are coming out, patients can have good distance vision and then get maybe some of the advantage of the presbyopia correction with those drops as a secondary if they're not the candidate for those extended depth of focus lenses or the multifocal lenses. I think that it's also important to shy away advanced glaucoma patients from monovision. If patients have, advanced glaucoma, say in one eye and not the other, you don't want them to be at a setup for having difficulty with their vision later on if their glaucoma is still to continue to progress, which it's more likely to do if they're advanced. So you want to shy them away from those things. And anyway, they could always go with the vision at the distance at the same plane, and then use a contact lens for monovision if they would like to do that.
Excellent. Well, no, thanks again, Constance, for the wonderful talk and the insights. We really appreciate you contributing to the program today and for all your insight.
Hey, want a must-need glaucoma tool that you can download right now? Well, check out my post-operative MIGS management strategy guide. It's a step-by-step treatment roadmap for routine MIGS cases. Look for the link in the description box below. Want more videos like this? Check out the iGlaucoma YouTube channel library. Check out the upcoming Season 2 of MIGS Success Surgical Secrets, where a video of common challenges and solutions will be featured. Subscribe to the channel so you won't miss it. Thanks for watching the iGlaucoma YouTube channel, a place for glaucoma innovation made easy for eye care professionals.